So, a warm, respected Chair, a warm good morning to all. At the outset, I thank Dilip for the opportunity, and my talk is not exciting or anything much on a case-based stuff. It's more of like a journal club that you would see in your DM dates. So it's about what's new in the field of CSP and what is the new evidences that has come forth in the last 2 years. That's what I'll be dwelling on. So let's start on with what's the most starting of publication in 2022 was the Geisinger-Rush CSP registry on a subject which we knew very much, but it has this Geisinger-Rush registry from the pioneer Vijayaraman sir and Parikshit Sharma. They actually established the fact that CSP is clearly superior to right ventricular pacing, which showing statistically significant reduction of QRS duration, mortality, heart failure hospitalization, and need for CRT upgrade compared to RV pacing, and more so in patients who have more than 20% pacing requirement. So this is a well-known fact, but they put the fact on paper with this registry. Similar thing was echoed by a Singapore group by Tan et al., where they showed similar results, statistically significant reduction in mortality, heart failure hospitalization, and CRT upgrade in patients with CSP compared to RV pacing, especially people with pacing more than 20%. Now, the MELOS registry that was alluded to earlier, it is actually from a multi-center European registry from 14 European centers with almost 2,000 patients, where they found the overall success rate of left bundle branch area pacing in Brady indications to be 92% and for heart failure indications to be 82%. But the more intriguing thing in this was the complication rates. It is very reassuring to see that the complication rates are not that high. It is 8%, but majority of those complications dwell on to the septal perforation from the lead, which is 4%. So this is a benign complication, and none of the other major complications have been alluded to. So it's more reassuring, and with a success rate of 92%. Now, in the real world data, what the US looks at is how CSP is effective. We have data from more than 2 lakh leads, and it is very safe and effective in the real world experience. The Europeans also echo the same. They did a physician survey. They found that there's increasing use of CSPs more. Lumenless leads take the lead here. Now, some of our concerns when we start off this therapy have been dwelled in with. In young patients, it is very safe with equivalent success as the adults. So this is a publication in pediatric cardiology where it showed similar success rate. In elderly patients, more than 85 years patients, again, this is a publication, Nature Scientific Reports, which says equally effective results with CSP in patients more than 85 years. Now, stellate-driven versus lumenless lead, it's always a controversy, but all these studies show similar outcomes, similar implant success rate with stellate-driven leads or lumenless leads, operator choice. It's about the technique rather than what hardware is used. Although stellate-driven leads have shorter implantation times. That's the only thing that was found to be statistically significant. And this is what was was echoed by Hallenbury and group as well from the European Society, where they found similar results and implant success rate with SDL versus LLE, lumenless leads. Now, some of the modifications that has been suggested in last 2 years is when you're using a stellate-driven lead like Solia, it is better to give an angle, at least a 35-degree angle, which will ensure more of the electrode into the septum, and which will ensure at least 18 mm 18 mm length of the pacing lead into the septum to avoid the vulnerable point being outside. And CLS, a closed tube simulation, equally works well with left bundle branch area pacing as well. And they also looked at this concept of lead fractures, which have been reported with stellate-driven leads to the tune of 0.6%. They found that this is the vulnerable point that we all talk to. This is the vulnerable point. So if you get 13 mm into, you can avoid this fatigue fracture, which happens when there's abrupt bend more than 12 degrees in about 1.3% of patients. So this is one thing which has been dealt in the bench testing to avoid a conductor fracture in stellate-driven leads. Again, in left ventricular septal hypertrophy, there is some publication which says that stellate-driven leads have an advantage of getting in very well deep in and getting good pacing parameters. One thing that was earlier shown by Deb was the continuous lead stylet pacing facilitating a left bundle lead implantation, which has been published which shows that a beat-to-beat real-time monitoring of impedance and pace QRS definitely goes a long way in ensuring good success. So this is the concept that was again alluded to. The moment you lose His-Purkinje capture, your ventricular septal pacing outcomes are just similar to what you do with the RV conventional RV pacing. So it's important to maintain capture of the conduction system. The moment you lose this Purkinje capture, this is what happens. This is publication from Shanmuga itself. A lot of in the last 2 years, if you see, it's publication from Shanmuga himself. So this is one concept that he has alluded to: new onset LV dysfunction after left bundle branch area pacing. He found it in about 3% of patients, and the major reason was loss of conduct system capture, suboptimal AV delay, AF, and idiopathic. So this happens in as long as 9 months after the initial implant. Re-interventions definitely corrected this, but it emphasizes the fact that you need to periodically assess in the device clinic, because new onset LV dysfunction might be because of loss of conduct system capture. Again, post AVJ, there's data which says CSP is superior to RV pacing. It's a no-brainer. And again, there's good data which says that left bundle branch area pacing is better than his bundle area pacing. The LB versus CRT, all data universally show that there's lesser QRS duration, lesser mortality, lesser heart failure hospitalization, and better NYHA improvement with left bundle branch area pacing. This is a publication in JACC. Similar publication in Heart Rhythm, which says similar results. Another registry in Heart Rhythm, which says similar results. But all data clearly show that left bundle branch area pacing is superior to CRT for major outcomes in resynchronization. And the moment you lose the conduct system capture, you have LV septal pacing, the outcomes are dismal. So this is again when you need to when you're extracting a CRT, it is probably wiser to go back with a left bundle branch area pacing rather than putting a CRT again. Now, hot CRT, clearly this data shows that hot CRT is superior to a conventional BIV, and this has been published in JACC EP. LOT ICD, that is again, so the conventional ICD, in addition, in the pace and sport, we place a left bundle lead, which showed to have a stable R wave sensing. It was in fact a better cost-effective resynchronization way with lesser fluoroscopic exposure. So we have a DF1 system where you have pace and sport being connected to the left bundle area lead, and this is what is called the LOT ICD. Now from there, they went to the next system of implanting an ICD lead directly into the left bundle branch area, which is called LBB-AD, which is left bundle branch area defibrillator lead. First in human feasibility study was published in 2023, and then in 2024, they published the first in human experience and the short-term follow-up. They found it successful in about 11 out of 12 patients, and Shanmuga also published this. Actually, this is a standard ICD lead through the conventional sheath getting into the left bundle branch area. So this is the standard ICD lead, and this is Shanmuga's publication, which showed a success rate of 62% when we're using this. And one step ahead is, if you are able to get your defibrillator into the left bundle area, you can actually do a single lead CRT with a DX IC lead. You have atrial sensing from the DX IC lead, and your defibrillator is in the left bundle area. So you have a single lead CRT also feasible, which has been shown in. Now, RV activation pattern during left bundle branch area pacing has also been described. 3 patterns: type 1 being through the conduct system, type being through the myocardium, and type 3 being a hybrid of both of these. Again, Shanmuga will be alluding to on this. Right-sided approach again has been shown to be safe and effective with about 84% success rate with the conventional C315 sheath itself. As I said, if you do it for any kind of QRS, if you have a narrow QRS or right bundle branch QRS, you will preserve the synchrony. For left bundle branch block morphology, you will improve the synchrony. Well, trunk versus fascicle, again, this has been compared well. Majority of time, you will end up with the fascicular pacing, as was alluded to by Deb, and it has almost equivalent electrical synchrony and pacing safety compared to the trunk. So this is what has been shown in the studies. When you're doing a left bundle branch area pacing, you end up with septal pacing in 23% of patients. In 76%, you do the left bundle branch area pacing, and out of which only 12% of times you are in the trunk. In about 40% you're in the posterior fascicle, 46% you're in the septal fascicle, and 12% you're in the anterior fascicle. How do you differentiate between these two are based on your morphologies in the inferior leads. When you're anterior, you will have inferior leads positive, your AVL will be negative. When you're on posterior fascicle, you will have inferior leads negative and AVL will be positive. Your trunk versus septal fascicle will almost look the same, but septal fascicle will be slightly broader. Now, if you want to, this is again a publication from our own from India itself, where they used how to do a left bundle branch area pacing in a non-EP setting. You can use a modified V1, V6 lead and a TMT ECG to just do it with a conventional PSA itself. TechSpam study is another one thing which eluded our fears of extraction of lead, where they extracted 341 leads, out of which 321 are lumenless leads, and 20 were stellar-driven leads with good amount of success rate. So they had a 99% procedural success rate of extracting the conduct system leads, only 2% minor complications, 95% were re-implanted. So the predictors for need for extraction tools were just two. One is diabetes and long lead dwelling times. Now again, atrial resynchronization, another thing that is coming up much. So just like the ventricle, you can resynchronize the atrium with either a handmade stylet which goes and paces the lower end of the atrial septum, or as our own colleague Muthaiya Subramaniam Narasimhan sir's group showed, you can use a sheath-assisted, electrogram-driven, a backbone bundle branch area pacing with a stylet-driven lead to get atrial synchronization on. Now, I'll conclude with this. The last 2 decades also had brought the EHRA clinical consensus statement on CSP, which clearly depicted the guidelines or the consensus statement on what are the criteria for achieving left bundle branch area capture. This is the 2023 Heart Rhythm Society guidelines, which gives a 2A indication for CSP if your CRT is ineffective, and 2B indication for CSP upfront, and 2B indication for CSP even if you are doing for patients with AVJ. And the last breakthrough, or the biggest breakthrough that I would say that has happened the last week or so, is the hybrid of conduct system pacing as well as leadless pacing, where Abbott actually announced the first in the world leadless pacing procedure directly into the conduct system. So this would be a hybrid of the latest innovations, both the leadless as well as the conduct system pacing, where you have a leadless device going into the left bundle branch area pacing and giving you a conduct system pacing. So that's the latest development that we have, which has been published a week back, that is on December 17. And this would actually really open up arenas and making up of the hybrid of best of both the worlds. So that's all from my side. I'll be happy to take on any questions.
I think, yeah, so we got wiser what happened in last 2 years with Arun's talk, and we also, looking at leadless system with conduct system pacing fusion, how we do that, and especially the Abbott system, the delivery catheter is I tell them always, this is a super catheter they have made. This is such a atraumatic distal end, and it can go to 360 degree. You can turn every turn around, and you can go and fix your lead and capsule, leadless capsule at a place where you desire. So Arun, can you elaborate us exactly how they are doing with this conduct system?
Doesn't make any sense.
Yeah, so we have implanted 4 of Avirs till now in the last 1 month. So what we have found is, as Dilip rightly said, they have a safety sheath over it, so it ensures that you are not traumatic compared to the system that we had earlier from Medtronic. We are not worried about with the safety sheath in, we can just give any amount of clock. But this device that is being alluded to by Peter Newsell, Vivek Reddy and group, it's actually a newer device. It's not the conventional Avir LP that we have. It has a extended helix at the tip, which actually goes into the septum and achieves conduct system capture. So it's not the conventional Avir that we have, which we have been implanting in the last month or so. It's actually a slightly different device with an extended helix, which is going to penetrate deeper into the area of conduct system pacing. And this is only in only the first preliminary study that was done in Prague in Czech Republic, and it just showed that this device is feasible. A lot of engineering needs to be done to get it into the conventional delivery system and to make it feasible on a long term.
Any comment from chairpersons?
We have been enlightened on a topic probably some of our cardiologists are doing, but it is excellent knowledge for all of us, and we can try and bring in this type of pacings in our practice. Thank you very much.